This is a project that we actually did at the hospital through my doctoral studies. And so we basically implemented a quality improvement project to reduce antibiotic use and lab tests in the evaluation of early onset sepsis. And so I have nothing to disclose as far as this presentation. And so the objectives, we're going to look at the background and significance of EOS. We're going to look at ancillary lab tests and predictive values. We're going to explore our baseline data that we collected in 2016. We're going to review the implementation of the new guidelines that we set forth, introduce the neonatal early onset sepsis calculator, examine the findings from the quality improvement project, and then we're going to identify those AAP recommendations and some implications for practice. So the statement of the problem, we know antibiotics are the most commonly prescribed medication in the NICU. And there's truly a lack of consensus among providers, between pediatricians, nurse practitioners, neonatologists. We are aware that newborns are treated up to 10 times more for culture-negative sepsis than actual infections. And so that's where the problem lies. And so we look at the background of significance. EOS is defined as a positive blood or cerebral spinal fluid culture for a bacterial organism within the first 72 hours. There's multiple differences in the last decade between the CDC's GBS guidelines, the National Institute of Health and Care Excellence from England, and the AAP guidelines have put out 3 different clinical reports in the last decade. And so why are we concerned about the antibiotic uses? The consequences, they alter the microbiome, especially in the preterm babies. There's an association with childhood obesity, atopy, bronchopulmonary dysplasia. In our preterm infants, late onset sepsis and NEC, along with multi-resistant drug organisms and death. The majority of newborns do not have EOS, but in this facility, we tend to treat 60 to 70% of those newborns upon admission to the NICU. In one study, there's a 4-fold increase in late initiation of breastfeeding and a 2-fold increase in formula supplementation in well-appearing term newborns who receive early onset sepsis evaluations. And so this is the 2010 GBS algorithm. The issues with this guideline is the EOS evaluation and empiric therapy occurs basically to all newborns who are not well appearing and those exposed to choreo. In addition, inadequate GBS prophylaxis with this guideline suggests EOS evaluation in preterm and term newborns with prolonged rupture. And so in 2012, the AAP came out with the management of neonates with suspected or proven early onset bacterial sepsis. The problem with this is, the most glaring part is they want you to continue antibiotics even if the culture is negative due to abnormal lab values like CBC and CRP. In a retrospective study, it was over 1,000 newborns greater than 37 weeks. They used these guidelines, and there was an increased utilization of diagnostic labs and increase in empiric antibiotic use with minimal yield because there was such a low incidence of sepsis. This is another study that evaluated the 2012 guidelines on choreo. And the main things are that 24.2% of newborns were treated with prolonged antibiotics greater than 7 days. And another 20% were treated based solely on abnormal CBC and CRP. In addition, LPs were performed on almost 22% of these babies, and they were all negative. And as you can see, the incidence of early onset sepsis was only 0.7. Like we talked about, the NICE guidelines is basically out of England. Before the guidelines, 20.9% of newborns stayed greater than 5 days. It increased following the NICE recommendations and led to increased length of stay and antibiotic therapy. Increase in LPs were performed, and subsequent CRP measurements were also followed, which contributed to the increased antibiotic use and length of stay. And so in 2015, the AAP comes out and says, hold on a second. We know most treated infants will not have bacterial infections. Abnormal CBCs and CRPs should not justify empiric therapy beyond 48 hours. And the policy of treating well-appearing late preterm and term babies that are exposed to choreo is not evidence-based. And I work in several different facilities through Mednax in Texas and some other states, and we were not treating a lot of choreo babies, and if they were asymptomatic, and they were just basically stayed in the nursery. Now in those units, we actually saw the nursery babies too, so there's a little closer follow-up. So when we look at white blood cell parameters, you can see that the negative predictive value is obviously great. The positive predictive value leaves a little bit to be desired. And that's why the cultures are truly the parameter. And we'll look at that in a second. And so we know this is another study with over 67,000 newborns. There's a poor sensitivity for white blood cell differential and platelets. You can see the highest likely ratios associated with a white count that's really low, less than 5, an ANC less than 2,000, and I to T greater than 0.3. And so the sensitivity that we noticed from this study improves when those labs are drawn after 4 hours of age. And we'll discuss some changes that we made in the NICU. And so this is another study that looked at positive predictive value and negative predictive value of the different labs. You know, just as long as they're negative, it makes you feel more comfortable. It's when they're positive that providers get concerned, although there's not a good predictive value for it. And so just quickly on CRP, can be elevated in relation to stress. The values normalize slowly, which limits the evaluation in response to antibiotic therapy. And I know some providers have talked about, well, the CRP went down because the baby's on antibiotics, and that's not truly the right idea about it. In our baseline study, CRP's cost was $170,000 in the evaluation of early-onset sepsis. And so when we look at incidence of EOS, this is a multi-state, a single center, the 16 NICHD hospitals and another multi-state study. Most of the literature you'll find reveals an incidence between 0.5 and 1 cases per 1,000 live births. This is another study by Dr. Schrag. It's a multi-state incidence over 10 years. There was almost 1,500 cases of positive blood and CSF cultures. And you can see that the incidence is still low. GBS is hovering around 0.3 to 0.25%. And E. coli is really low, and then the overall incidence is still less than 1 per 1,000 births. And so this is where we started our unit. We were in the top 15% in unwarranted antibiotic use, and that's antibiotics greater than 72 hours with a negative culture. Our average days of antibiotics, infants that were started on antibiotics, was greater than 4 days. And our overall empiric antibiotic use was almost 74%. And so I had an idea that I'm going to collect this baseline data in 2016, and I wanted to see if there was a relationship between abnormal ancillary lab tests, CBC and CRP with negative cultures, and if that affected our antibiotic use greater than that rule-out period. And so our hypothesis basically came to fruition. The drivers of unnecessary antibiotic use with those negative blood cultures, abnormal CRP at 6 to 12 hours, at 24 hours, abnormal CRP beyond 24 hours, and CBCs beyond 24 hours. And so our gestational age, there was a significant association across all gestational age groups receiving antibiotics. And I highlighted the term babies. 50.5% of newborns at that term were treated with antibiotics greater than 48 hours, when that incidence is lower, much lower, 6 to 10-fold lower than these preterm babies, less than 33 weeks. And so when we look at blood cultures, 92% of newborns who received those antibiotics greater than 48 hours had a negative blood culture. That was significant. Now, I have this on the side because, and I'll show you with the next slide, in a couple slides. We know that with these culture bottles, 99.7% of these cultures should be positive for a pathogenic infection by 36 hours. And so there's a lot of practices that are going to 36-hour rule-outs, even within our company. And I'm not sure if y'all familiar with the cultures, but there are actually some resins in there that inhibit, or they neutralize the antibiotics from affecting bacterial growth in that sample, okay? And so I also looked at the rate of pathogenic EOS at this facility per 1,000 births. And our mean is about 1.44, so we're a little higher than, say, the national average. Although 99% of the newborns born at this facility did not have infection. Now, this is somewhat troubling here. The contaminant versus pathogenic blood cultures in this facility was over 75%. And we went to, in the NICU, went to drawing everything sterile. And that's actually what it says in the manufacturer's pamphlet. It should be drawn in a sterile fashion. Now, we feel that probably the phlebotomists from the lab, they're not drawing it that way. So the good thing is our pathogenic, our contaminant rate has gone down, but it's still fairly high. And this has been brought to the lab's attention. And so how do we get here? History, tradition, yes. Unfortunately, there's not a ton of randomized control trials. And we're finally, with the AAP's new guidelines, getting closer and closer to more of an evidence-based practice. And so here's the calculator. This is what it looks like. We can, the website, it actually, we can click on it if y'all want. We can do it towards the end. But basically, this assessment tool is determined to determine the newborns at the highest risk for early onset sepsis. There's a threshold for a blood culture at 1 per 1,000. So if this score here, let's see if I can figure out the pointer. If this score here is 1 per 1,000, here it's going to recommend doing a culture. If it's greater than 3 per 1,000, it's going to suggest empiric antibiotics. And all of these maternal risk factors on the side is what they predicted for early onset sepsis. So in our study, the CDC incidence we used was 0.5. So another thing about the calculator is when I go to assess the baby, I put in the scores and I have the baseline maternal risk factors, but then I'm there to assess that infant. You look at clinical illness. So is the baby on CPAP or high flow? That would put the baby in clinical illness. A HIE baby. Baby's on dopamine. Equivocal would be like maybe a transitioning baby from a C-section that's still to kidney but not really requiring oxygen. And then you have well. And it provides those different scores after your examination. And so the people in the calculator, you can look at the rate of EOS within that cohort, which is over 600,000 babies. The rate of per gestational age, you can see that at late preterm to term, it really starts dropping off. Same thing with the rate of maternal temp and the rate of rupture of membranes. So that 102 temp, that rate of sepsis is really high. That rupture of membranes around 24 hours really puts the baby at risk for early onset sepsis. And so it was a case control of 608,000 babies, multiple facilities out of California and Massachusetts. The most important predictors were antepartum highest temperature, gestational age, duration of rupture membranes, the duration of IAP, and if mother was GBS positive or negative. And that's how they came up with the things that you plug into the calculator. And so so basically for the validity of the calculator, had a cohort of 205,000 babies. Their blood culture use decreased from 14.5 to 4.9%. Empirical use decreased from 5 to 2.6%. Now, in our facility, and this includes newborns, in our facility, the percentage of newborns that receive antibiotics compared to the babies that are delivered per year is averaged about 14.5% from 2010 to 2018. So our antibiotic use is really high when you look at this group out of California, Massachusetts. The incidence culture confirmed sepsis was similar during all periods, and the readmissions was similar. And so here's another graph of the baseline period, the learning period, and the calculator period. The first one is monthly antibiotic treatment rate, and you can see it decreased significantly, and EOS evaluation rate also decreased. And so this is another look at the calculator, and I'll show you another slide towards the end, but this is the quantitative risk stratification for the calculator. And so one of the main things is this group right here that has This group here is your least lowest risk infants. They have a score less than 0.65 at birth, and they're well appearing. The number needed to treat for one infection is over 9,000. And so, hit the implementation. We revised the guidelines that were basically done in around 2010. We eliminated routine CRPs from the early onset sepsis workup because of the relationship between continuing antibiotics. We introduced a calculator for greater than 34 weeks. We are treating choreo babies different. And we were suggesting that LPs be done prior to any antibiotics if needed. And so, just real quick, it was a pre-post interventional quality improvement project. And so the initial baseline period we had 346 newborns. The intervention, basically, as we revised the EOS guidelines due to the baseline information that we had. The post-interventional analysis, I gave the providers in the unit a 1-month learning period, and then we had a 4-month chart review afterwards on the changes. And that was all due just because of the doctoral studies. And so the aims of the quality improvement project, we wanted to determine the number of antibiotic treatment days, appraise the number of EOS evaluations. We also wanted to look at clinician adherence with the guidelines. We also wanted to review that antibiotic use greater than 48 hours with negative cultures and see if the calculator had any effects on antibiotic use in those late preterm and term infants. And so when we look at the overall mean antibiotic treatment days in the baseline period, we're at 2.94 days. In the prospective period, we're down to 1.5 days, and that's after the implementation. There's a 60% improvement or reduction in overall mean antibiotic treatment days. And I broke it down by gestation, late preterm to term, and preterm, and there was in the preterm infants another 61.6% reduction, and in the late preterm, which is the majority of our admissions in NICU, we're down 94% in antibiotic treatment days. And so antibiotic utilization rate, the CDC, it's a way to track antibiotic use, and they go by days of therapy per 1,000 patient days. And so as you can see in our baseline chart review, we were at 212 overall and 190 with negative cultures. And you can see the reduction. September, we had a few infections during that month. And this is another side. So if we looked at that overall days of therapy per 1,000 patients, we had 212, and we were down to an average of 147.6, which is down 36%. And so I wanted to look at, okay, the overall includes infections. Let's see what it looks like without infection. So we went from 190.4 in the baseline period down to 121.9 days of therapy, and that's down around 44%. And so our overall empiric antibiotic use, we were at 73.7%, and during the prospective period, we were down to 57.1, which is significant. The antibiotic use greater than 40 hours, which is amazing. We went from 31.5 down to 8.2%. And then for the majority of our admissions, we were right at 70% on the baseline, and we were down to basically 51%. Now, all of those were significant. So we think the calculator has some effect with those late preterm babies. And when we compare the gestational age and antibiotic use greater than 48 hours, you can see by gestational age, we've dropped pretty significantly overall, and through the different gestational ages brackets that I have. And so empiric antibiotic use, and this is for newborns greater than 34 weeks. This is just another slide that we had a 26.9% reduction in empiric use, and greater than 48 hours, we were down 72%. Another thing we wanted to look at was ancillary laboratory tests. Every baby that came into our unit in 2016 got a workup. It didn't matter if it was NAS, freckles, whatever. We did a workup on the baby. And so we wanted to look at the different cultures. We went down to 84.8% during that time. The LPs, we had a pretty significant decrease. I know it's 6 months to 4 months. The CRPs were down 192%. I'm not sure if, I can't remember his name, one of the pediatricians, if y'all got the memo about the project that we were doing, if he sent an email to y'all. Because I noticed even the pediatricians in the 17 CRPs were from a couple of the pediatricians in the nursery and outlying facilities. We also decreased CBCs by almost 50%. Now, out of those 17 CRPs were drawn, we had one provider in the NICU that drew a couple of them, likely by accident. And another thing we wanted to look at was cost-benefit analysis. Now, these costs are based on what the lab charges to the consumer. And so that baseline period, we spent approximately $486,000. The prospective period, we were down to $186,000. Now, that's a 6 month to 4 month, but you can see if I added a couple more months to the 185, we'd still be probably halfway the cost as far as looking at early onset infection. Provider adherence. Unfortunately, I was not able to discern the NNPs from the docs because basically it was the doc, the NEO's record of on the admission note who was put in the provider adherence. And it actually was pretty good to be honest with you. We averaged 83% with the new guidelines. We know providers have a difficulty with change, but there were still 36 opportunities to reserve antibiotics during that prospective period. Y'all remember this quantitative risk stratification? And so if you look at the highlighted areas right here, we treated almost 60% of the babies in this period, and about 25% received antibiotics greater than 48 hours. And these babies are at least at risk. And these were probably newborns that didn't need to be treated. And so we went down to 12.5% in the respective period, and only one baby got antibiotics greater than 48 hours. Now what's interesting is, if you look at the clinical illness down here, so this is some of our sick babies here. We treated 69% here before the calculator. After the calculator, we treated 79%. And the question is, why did that happen? It's likely because before we were looking at the maternal risk factors. For example, if a 38-weeker had PIH and came to the NICU and was on CPAP, we didn't start antibiotics on that baby. But with the calculator, people were not looking at a maternal risk factor and just doing what the calculator said. And we kind of thought that would possibly be something that showed its face during the study. And so some additional notable information for infants exposed to choreo. We went from 100% to 56%. There were no positive cultures in any of the data collection periods. There was 5 cases of late-onset sepsis, 1 case of NEC, and 3 deaths. There was really no consistent pattern. We did see an observation of less NEC and late-onset sepsis during 2018. 2 newborns were readmitted within a week of discharge. One had severe cardiomyopathy, and the other one was hypothermia. All bacterial viral cultures were negative on both newborns. In addition, You know, you have to have the maternal temperature, intrapartum temperature, and some of the outlying facilities, it was a task to get that information. Now, there was a couple cases where the calculator failed to recommend an evaluation, so a blood culture, and 4 newborns with positive cultures. 2 of them were contaminants, and 2 of them, one was GBS and one was Enterococcus. Now, this is what happened. One baby with GBS was in the nursery, started getting sick at 7 hours. A pediatrician drew a blood culture, CBC, in the nursery. The kid came over to our unit. We put the baby in a calculator. There was minimal risk as far as the calculator. And the baby was on 1 liter cannula, I believe, 21%. So he fell in the equivocal category, and he said, you don't need to draw a culture. We already have that one cooking. We're going to watch the baby. The blood culture came back positive at 12 hours of age. We repeated the culture, did an LP within 18 hours of that other culture, and both of them are negative, which is a little ambiguous. The same thing for the baby with Enterococcus. That baby was in the nursery doing fine. I don't think he was transferred in the culture until the culture was positive. The culture was positive. We did an LP and another culture before antibiotics, and they're both negative. I don't know how to explain it. And so that was a little odd. Those infants were treated for 10 days each, but it's a little ambiguous, those 2 cases. And so in September, during the data collection period, the creators of the calculator added more incidences into the calculator that you could plug in. And so we made a few changes. Now, this is 2019. The data's not complete, obviously, but our unit has gone from down to 62 from number 11 out of 72 large volume units that are in our data warehouse. You can see the unwanted antibiotic use is down to basically 4%, and our average empiric therapy of the babies that are started on antibiotics is down to 3 days, because we were sitting at 5 days, close to 5 days for many years. And so some implications for practice. Hopefully we can decrease consumer and healthcare expenditures. Has the potential to reduce hospital stay and associated morbidity, and hopefully we can improve those long-term neonatal outcomes, and maybe some of those infants will not have the issues with the extended antibiotic use. And so our project sustainability in November, we started using the 1 per 1,000 in the calculator, and we collected an additional 4 months of data. In April, I presented all the results to the staff, the NICU staff, and the providers, along with the nurses. We changed the time frame from birth to 24 hours for the calculator use. So if that baby comes from the nursery, it's 14 hours. We can still use the calculator. Now, if the clinician wants to work the baby and put the baby on antibiotics, they have that option, okay? But you can still use the calculator. Our antibiotic use beyond the 48-hour rule out is still declining, and our provider adherence improved during the additional 4 months. And so during that post DNP data collection, we had 193 newborns. The gestational age, all the demographics are fairly similar among all of them. We talked about the provider adherence. It actually went up to 87%, but there was still another 25 opportunities to reserve antibiotics in that 4-month period. And so we looked at, was there any significance between the prospective period and that post-DNP period, and there wasn't. We went from 1.5, 8 days, down to 1.4, which is, we're still improving in that aspect. Post-DNP antibiotic outcomes. So we did have about a 5% increase, which I was anticipating in empiric antibiotic therapy. Because of that, we increased the incidence in the calculator. But our overall mean days of therapy declined, and with including the babies with infection and the ones with negative cultures. And our antibiotic therapy greater than 48 hours was down to 6.2. Now, the babies that come in from referral hospitals, sometimes it's a little tricky in CPOE when you're putting in the antibiotic orders. And so for those babies with the extended antibiotics beyond 48 hours, the CPOE contributed to those. And so what are we doing with the choreo babies? And so asymptomatic newborns, we are allotting them up to 1 hour to facilitate skin-to-skin and breastfeeding. At that point, we have all the information for the calculator. We put it in. The baby comes to our unit, depending on what the recommendations say. If the baby remains asymptomatic and the recommendations say no culture, no antibiotics, we will look at that baby for 4 hours. If he's fine, we'll send him back to the mother to basically room in. We'll keep the baby. Some providers have kept the baby in the NICU care until discharge, and some of the providers have transferred the baby after the baby's been fine for 24 hours back to the nursery. Okay. There are some recommendations with the calculator that say observe the baby for 24 hours. And so those babies will observe in NICU, have the baby on the monitor. If they're fine after 24 hours, we can send them back to the nursery or keep them under our care, but basically send them to the parents in their room. And the key is appropriate observation. These babies need a minimum of 48 hours of observation, despite the method of delivery. And so when we look at the AAP recommendations, they should be customized at the local level. We know that EOS differs greatly between the term, late preterm, and preterm newborns. It's anywhere between 6 to 10-fold increase in early-onset sepsis between term and preterm. Use of the multivariate assessment for newborns, that's where the calculator comes in. I know it's difficult as far as the continued observation. It's much easier for us, obviously, because we're there all the time for those newborns to observe for clinical illness. The diagnosis of early-onset sepsis is made by blood and or CSF culture, not by CBC. Everybody basically uses ampicillin and gentamicin. And when blood cultures are sterile, antibiotics may be discontinued by 36 to 48 hours. I know there's even some practices within Mednex that are stopping them at 24 hours. The thing is, we talked to the lab about drawing cultures sterilely. We talked about doing a minimum of 1 ml and for the blood cultures. And that should provide, if you put 1 ml in there, even if there's a low-grade sepsis, they can still pick up on minimal coliform units with those cultures. Also, the GBS guidance aligns with these recommendations. And so to take home, we must remain vigilant in evaluating early-onset sepsis and maternal risk factors. We know that antibiotic therapy is not without harm. We have to continue to learn and adapt and review the literature. I find that there's not enough active and thought-provoking discussions on important topics that we deal with, and this is one that we deal with daily, on a daily basis. And we must be willing to change. We must adapt and change to impact healthcare for the betterment of our patients, consumers, and hopefully the healthcare system.